Welcome back. This is Dr. Stephen Mather again at the Spine Learning Channel. Today we're going to show you another case of how to do the bilateral decompression using the unilateral approach. Not only can you get to both sides of the spinal canal very predictably and easy, but also it'll show you how to put in two cages, and not only two cages from one side of the spine, but also we're going to pack a centimeter of bone in between the two cages. This gives you a huge footprint which prevents subsidence. That is, you're going to be getting a footprint as big as an anterior lumbar interbody fusion and a very predictable fusion. You'll be able to see the bone growing on the x-rays postoperatively, very easy. You won't have to resort to a CT scan, although sometimes we do get a CT scan in certain cases. If there's a delayed fusion from patients using biologics or there are smokers. But this represents a very, very transformative approach to doing minimally invasive fusion. You'll find that your results are far better than any single cage minimally invasive fusion. If you already know how to do the decompression, you can skip to the cages part, which is about halfway through the video. So sit back and enjoy. So we start out after we place the incisions and the initial retractor. We cut out the soft tissue. Here I am taking a right angle osteotome. I always start at the distal aspect of the facet joint. Distal is going to be on the right. And then I take out progressive pieces. I'll chop the bone down right to the upgoing facet of the level below. And then you can see exactly where this facet joint is. I'll take out pieces of bone by torquing on those pieces and remove those pieces of bone for our bone grafting later. And I use a very, very aggressive, very strong pituitary rongeur to take out these pieces. And I'll start drilling because now I know where the facet joint is, because we'll see the glistening cartilage there. I protect the ligamentum flavum, which is just above the suction. And I'm working with both hands here. The nice thing about the slotted retractor is you can brace yourself very nicely on the patient and get that drill out of your vision. We are still working on the facet joint. You can see where the facet joint is, right in the middle of the drill there. Some people save the drillings for bone graft. I don't do that. I don't think it has a lot of viable bone because the bone gets burned up. I go all the way, the drill takes me all the way to the very cephalad part of the facet joint. That's very, very key to doing the rest of the operation. Now I'm going to angle the retractor and I'm going to angle the patient. So here I am moving the retractor. Now I've got the retractor about 30 degrees, 40 degrees to the skin of the patient, and I've angled the retractors. I've angled the patient 30 degrees to the floor. So this really allows me to get to the opposite side. Still drilling away. After I've really thinned out the bone, then I start taking away the bone. If there's any concern at all, I will separate it with a fine curette or a Penfield 4. Joel Kim taught me this. You got to really make sure you got a good plane before you stick your kerrison in there, because you don't want to get a dural tear. I found that using the microscope and this retractor, a dural tear is almost unheard of. We might get one every 3 or 4 years, but we generally just don't even see them. And when we get them, they're very small, usually from a stuck piece of dura to the ligamentum flavum. Here I am going after the near side. Here I am at the proximal part of the facet joint, removing the ligamentum flavum. And now we're going to rotate. We're going to rotate the slot so that I get better access towards the distal opposite side. This is the hardest part on the contralateral decompression, is getting to that distal part of the facet joint. And I'm going to make sure that I get all the way around the pedicle on the opposite side. Kerrison rungers really are not made for the opposite side, so you do have to rotate that retractor to get you over there and get the right angle. Here I am finishing up. This is a 3 Kerrison rongeur that I will use. Rarely can you get a 4 Kerrison rongeur on the distal side. It just doesn't have the right geometry. There's still a little bit of facet joint left. I'll get a Penfield 4 elevator to separate the capsule from the nerve root. I get a nice clean plane. I push the dura down and the nerve root with the suction. Make sure your suction does not have any sharp edges, otherwise you will create a dural tear. So I'm always using the suction to push the dura down. Now I'm starting the discectomy. We've gone now back to the near side. I'm retracting the traversing nerve root, make my annulotomy. Chol Kim taught me this, and Kern Singh taught me this also. Make sure you have your annulotomy's got a nice big hole. Don't work in some small little hole. You want to take out as much annulus as possible so you can see in there and you can really feel without gouging the end plates. Again, I've got the traversing nerve root protected with the Love nerve root retractor. I'm using a specialized curette I call the backhoe. I developed this myself, and it allows us to get right under the posterior annulus, and now I'm using it on the surgeon side, the ipsilateral side, to cut into the more lateral annulus. You want to work with a really, really big annulotomy. My annulotomies will frequently be 16, 18, 20 millimeters in side-to-side distance. 4 millimeter Kerrison, taking out the annulus. Once I've removed some of this, then I will work in there with the dogleg curettes. But I really want to be able to see where I'm going, so I spend a lot of time making a big hole, make a giant annulotomy. And I'll use a trial. The trial really paves the way for getting both cages into this disc space. This is a 10 by 10 millimeter trial. And again, if you've retracted the nerve root, I do not worry about nerve injury. I'm putting in a little bit of eye factor here. This is approximately 2 cc's. I'm going to put in the first cage. You'll notice it's bulleted to go across the spinal canal. This one is 24 millimeters in length, 10 millimeters in height. And after that's in, we're going to push it across the spinal canal, underneath the dura, obviously. That's thing 1, which we use, and here's thing 2, a little bit bigger angle, push it over a little bit more. I have never had one of these cages go across and through the opposite annulus. The opposite annulus is so tough, I don't worry about it. Now we're going to put in the second cage. You notice it's bulleted towards me now. Now I'm going to separate the two cages. I'm going to push that second cage laterally towards me. Now I've got some gap between the two, but what they tend to do is the two cages tend to touch each other at the very front of the disc space. So I'm going to separate them with larger and larger trials. These are specially made trials. We first start small. Then we go a little bit bigger. Here comes the second trial. This is an 8 by 10 millimeter trial. So now we have a centimeter of bone we can pack in between the two. Generally start with the small autograft pieces. These are all pieces of bone either from the laminectomy or from the facetectomy site. Once we've got a fair amount of autograft packed in, we'll then come through with our 1 centimeter by 1 centimeter impactor. What the goal is here is to fill up the anterior 1/3 of that hole we've created. And once we've filled it in about 1/3 of the way, filled our hole 1/3, we pull up the impactor. We're going to compress the opposite side so we get some lordosis. And after that's been done, because the screws and the rod are in on the opposite side, then we'll come in and we're going to put in some big pieces of allograft. Here's another big piece of autograft. Pack that in. And this construct is so rigid, I have never ever had, in well over 500 cases, I've never had any significant subsidence, anything that I could see on an x-ray for sure. It's just a huge footprint. And after that, we've compressed, we'll put in more autograft bone, and once we've run out of autograft, I've had some 1 centimeter chunks of allograft that have been soaking in bone marrow aspirate. And we will tamp those in place. Now, because the level has been compressed top to bottom, and your final x-ray, side view, front view.